I mean, there's a lot of things to do, but a lot of things has been done. Both when we talk about primary prevention, when we talk about what you're doing when the patient has his or her MI, and we know very well what to do post-MI. There's a wealth of data that's been gathered over the last year, and we've got very, very well-defined guidelines, so it shouldn't be a problem. And we've come a far way, and I've been talking about the Sweetheart quality indexes before, which means that in a developed country like Sweden, with a public health system, the problem is shrinking, and it's shrinking fairly fast. But still, we've got, as you mentioned in the beginning, 17 million people dying every year, predicted to increase up to 2025. And so the scale is amazing, it's huge, and there's a lot more to do. And one of the main things that we can address, where we have the knowledge, but we have problems in implementing, I think, is secondary prevention. I would say in the best improvements in tackling secondary prevention would be tackling the main risk factors. And the first risk factor is to get the myocardial infarction. To have had a myocardial infarction means that you have a high risk of having a new myocardial infarction. Depending on how severe your first myocardial infarction was, I mean, if you have a multivessel disease, if you have post-MI heart failure because a lot of myocardium is dead, that really lowers the prognosis and increases the importance of secondary prevention. That's the first thing. And then if we look in the developing countries, we have the risk factors of an elderly population, that is the hyperlipidemia, hypertension, diabetes, renal dysfunction. I would say those are the main factors that we can, most of them by medication or changing of lifestyle, address. So therefore that is the big problem and the improvement that has been done. We know in Western Europe we probably halved the mortality in myocardial infarction over the last 40 years. And that's impressive. This is information from an epidemiology professor at my institution, that when I asked him what is the improvement in healthcare in Sweden and what is the change in lifestyle and how we live today compared to we did 30, 40 years ago, smoking cessation, smoking has gone down in Western countries and so forth. So therefore it's about 50-50, they say. But then if you look at what kind of myocardial infarction you get, you divide them into the STEMI and the non-STEMI. Where the total block STEMI, the medical technology improvement with coronary artery bypass surgery and PCI has really made a change. And you can see that the mortality benefit in those patients has been fairly dramatic over the last 20 years. Studies have shown that. But if you look at the non-STEMI, which then is not that acute, then they are perceived as lower risk patients. But actually a lot of registries have shown that those patients do worse. And therefore here I think is one of the things where you really could make a difference by addressing the secondary prevention and make sure that the patient has dual antiplatelet therapy, is on antihypertensive drugs, lipid-lowering drugs, make sure that they stop smoking. Probably that's number one. Especially gender differences, and I think that is probably one of the most important frontiers where we need to tackle the problem, because females do worse. About double the mortality compared to men. And that is shown not as much in Western countries as in developing countries. But still there's a big difference, and females do worse. And why do they do? We don't know that for sure. I mean, females in general are a little bit smaller, which means that maybe their coronaries are smaller. It could be a size problem. That could be one thing. It could be a symptom problem. That's been an ongoing discussion for many years, that females do not seek help at the same extent as men do. There are differences between men and female, but we shouldn't be treated different because of gender. And there's a lot to do there, and a lot of lack of knowledge that we need to understand. Well, you know, I'm coming out of a clinical situation where you, in some instances, had difficulties in having ethical approval of doing things, but you could actually fairly fast within the hospital try different things. Now I'm working in a pharmaceutical environment, and as I think you know, to bring the idea to a new drug to patients and to make it into clinical practice is a very, very, very long time frame. We can talk about something like 15, 20 years. And therefore, there is a need to speed up this without, I mean, it's very important to have the structure of safety before you do things, but it's also important not to delay the potential benefit that a new drug can bring to a patient. And therefore I think that those large randomized control outcome trials that we're running as a pharmaceutical industry is very costly and takes time and rigorous controlled. So I think there's a need to utilize and to build new registries and registry run randomized trials. Sweetheart is kind of in the front and frontiers of this, and I think that is probably a way to do something faster and in a way more comprehensive, because you don't select the patients in a way that you do in a randomized control trial. But baseline, it's difficult because you cannot exclude the randomized control trials. This will be a complementary way of reaching knowledge about new treatment options. They make decisions based on the information that they get, or should at least. And it's important to give them valid data on what's best for the patients. But then you have to realize the budget situation, which means that health economy, I think, is something that is very important. If you can show a politician that increasing the focus on secondary prevention after myocardial infarction, and show that in the end you will save money, and it's not his money, it's our money, right? It's our tax money. Then I think that is probably the best way to make a change and increase the focus on secondary prevention, because secondary prevention is probably where you can save a heck of a lot of money.